Legal disclaimer time. The opinions shared on Priority Air are those of Rob Fair, Chris Voller, and whoever we conned into speaking with us this week. To be clear, they don't necessarily represent those of any organization you may associate with us, but they do represent honest conversation, a bit of humor, and a lot of heart. Enjoy the episode, you guys. Thanks for listening.
All units, please stand by. Rob Ferrer and Chris Voller have priority air. Go ahead, the channel is yours.
Hey, thanks for joining us. You've got Chris Voller, Rob Fair, and today on Priority Air, we have Dr. Heather McEachern. She is a psychologist who works in the province of BC, but has spent a lot of time helping people throughout Canada. And we're going to get a little bit of time to get insights from her on what she's learned about police officers, what she knows about psychology, and perhaps some better ways forward for police officers. One, to practice healthy thinking, healthy lifestyles, but then two, to look for signs for others that we're around that may indicate to us, hey, these are individuals who may need a little bit of help.
Yeah, this could be awesome. I'm really looking forward to this. Should we call you doctor? Do you want to call you Heather? How do you want to?
You know what, Heather is fine.
All right, Heather. Really appreciate you coming on. And yeah, very interested in your insights. Like, Chris and I have both been cops. Just give you a little background. We've both been cops for a long time. I think we've got 40 some years between us, which is a good number of years. And there's never, I would say there's never a long period of time where we're not tragically, within a week or maybe two of a suicide of a police officer in Canada. That's not taking the US into account. That's just in Canada. And it's cross organizations, and it's also not just police. I want to be clear. There's first responders, but it seems that police seem to be leading the league in a lot of negative categories. So as Chris said, I think we just want to sort of pick your brain and see what sort of stuff we can get out there. And if we can start, creating resilience or whatever that looks like at an early age. So if you don't want to, give us a bit of an intro, let people know who we're talking to.
Well, you know what? Thanks for inviting me. I provide a lot of services to RCMP members and other first responders, as well as a broad population. The RCMP members form a pretty major part of my practice, and thank you both for your service. I have been providing services to members since 1993 to date myself. And in 1995, I became registered. I was supervised by some of the very first people to provide services to RCMP. And it all started, I don't know if you guys know this, but it all started because there was a higher divorce rate. And so they attached psychologists to help people, especially with remote postings, to make sure that you guys' divorce rates would come down to the normal population. It's hard on families, it's hard on individuals, and it's just been a real pleasure and honor to understand your jobs so that I can better support you. And this gives me a chance to do that for a larger group of people than I can reach 1 hour at a time.
Yeah, that's great. I'll start with that first question. You brought it up, how it started. Was there an impact, do you think, on, it started off as a relation to the high divorce rate, as a divorcee myself, I guess, like has that come down? Has there been any impact? Do you know?
The statistics have come down a bit, but it's looking like this. The actual national average for divorce is going up over the decades, as if there's more acceptance and understanding, and we have a longer lifespan. And when our grandfathers or grandmothers committed to a marriage, they'd be lucky to see 40 years, and then they'd get old and die. And now we live a lot longer too. So serial monogamy is more common, that you are in a long-term relationship and then maybe it stops serving your needs and you choose to move into another long-term relationship. So that has increased, but have the RCMP benefited from psychological services? Yes, they're not as disparate as the rest of the population anymore. Remote postings, the kinds of things that I've been participating in for the last 3 decades, we started like assessing people going into remote postings, including their spouses in the assessment, to make sure that they really understood the commitment. We provide couples counseling as well as individuals, so we can educate and inform a new partner to a member what it looks like. They're kind of disappointed if it's a general duty member and on the first of 4 days off, they're actually brain dead. So we have to kind of explain, and they're also full of anticipatory anxiety on the fourth day off. So they really only get 2 good days out of them. When we start to talk about this and explain it to the supporting member of the family, the spouse, we also have room for treating children in the context of helping them, so that you get wraparound services. And it's come a long way. It's quite good. But I would say the people that I'm talking directly to are benefiting, but there's a lot of members that don't even know they could just call a psychologist and see one as part of their benefits package. In fact, a lot of them just think there's a 1-800 number, and that's a very different service that I don't recommend.
So, with respect to that, Heather, then, I myself have done a couple isolated posts. So, my family and myself have gone to talk to psychologists, got screened out, managed to get ourselves to those postings. But I agree with you. I think the RCMP and the policing as a whole are moving in the right direction with mental health, with the acknowledgement, one, of even just saying, hey, this column's a lot higher for police and peace officers than it is for everyone else. And then
Right.
taking a look and saying, well, why is that? And then employing professionals like yourself. For the most rudimentary aspect of this, though, can you tell me the difference between a psychologist and a psychiatrist or a counselor?
Yes. And it's a good question. I trained alongside fellow psychiatrists. So that's my very loud dog door. My apologies. I have large dogs and one just chose to exit stage left. So we have my training is an undergraduate degree in psychology. I also explored other things like the sciences and English literature, etc., and then got an undergraduate degree. That's a 4-year program if you do it efficiently. Then I applied to be a graduate student in psychology, a master's in clinical psychology. That's what I applied for. I actually ended up doing a health version of this, so that I was more aware of physical and the health that one might receive at a medical doctor. And I looked at the relationship that people have with medical doctors. So I'm doing my master's. I'm in hospital settings. I'm practicing counseling, learning about diagnoses. And then I enter into the doctoral program, where I'm doing an internship, learning more about diagnosing and treating individuals with mental health issues. At that point, my psychiatry colleagues join me. They have gone through and gotten a medical degree. They were undergraduates. They applied to medical school. They all became a general practitioner. That's the opt-out level. And then some of them chose, no, I'd like to specialize in mental health. And so after they become a general practitioner, they move into a mental health specialty area. And they join me at that point. But I've been studying mental health as an undergrad, studying what's normal and what's unusual, and how to move people from unusual back to normal, if at all possible. Normal cognitions, normal thoughts, normal emotional responses, a normal range of emotional responses, normal behaviors, and then identifying what's abnormal, and then looking at moving people back. The psychiatrist knows how your body works, just like your family doctor does, and they have a cursive knowledge of mental health, and then they get thrown into psychiatry. And at that point, now they're going to learn how to interview people, diagnose people, and treat people. A lot of them that were working alongside me at Alberta Children's Hospital, which is one of the places I trained, they were like, how did you develop so much interview skills? And it's like, well, I've been practicing these for years. And for them, they're just now specializing. They could specialize in surgery. They could choose all sorts of different things, but they're specializing in mental health. So they are a medical doctor with specialty training. And many of them are they're overwhelmed. They're going to go to a medication choice for their patients to help address the physiology of their mental health, to help calm their system and help them to sleep and help them to be less anxious or less depressed. My role is going to be to support that if medication management is helpful, but primarily to do therapy, psychological therapy based on evidence-based literature. So when people come to me, they say, I don't want you to medicate me. I say, don't worry. I'm not a prescriber. I don't have any rights to prescribe. I'm going to offer you talk therapy and strategies that will hopefully give you some resiliency training and make a difference for you. And what's the difference in a counselor? The biggest difference is that I am a diagnostician. I have equal status to a psychiatrist in providing a diagnosis. I'm also an expert witness in all levels of court in British Columbia to the Supreme Court in my diagnostic abilities and my abilities to form a professional opinion. And I don't have to wait as long when I get invited to court as you guys do. They actually schedule me in and apologize if I miss lunch. So it's a different experience than police officers have when they're called to court. So yes, I'm a diagnostician, a counselor, someone that would be like a registered clinical counselor or a registered master of social work. They can help to reduce symptoms, and they're very good at it. We have some amazing people at Kelowna Professional Group, which is our sister group to our psychologist group, and they do great work in symptom reduction, but they're not in the position of providing a diagnosis. And that is a major difference. And they don't have as many years of training. My colleagues with a master's in social work, what sets them apart is they have a number of years that they have done the work, because I take senior people with good experience, but they would have gotten out of school in 7 years. It took me 14 because we have to be researchers and understand the research. We have to be practitioners, and we're also supposed to be educators. So I have taught at university. I have published research, and I am quite aware clinically of what evidence-based practice to utilize, and I can assess.
That's very interesting. The diagnosis piece, I think, is very important for because if you're looking for down the road things, or if you have a long-term thing, which we can get into, I think that the diagnosis becomes incredibly important.
I think it is, and you're all aware of that now, Rob. I mean, you can look online and list off your symptoms to ChatGPT or some other resource, and you can actually, or you can talk with your colleagues. And I know there's RCMP mates. I'm not part of that, but you guys can talk with each other, and you can say, geez, maybe I have PTSD, maybe I have anxiety, am I obsessive? And yeah, a lot of people want that answer. So if they're looking for symptom reduction, we triage, and they would see someone for symptom reduction. But if they'd like a diagnosis, a psychologist will come in for a consult, or we will be the primary person providing the service.
Okay, go ahead, Chris.
Can I ask a twofold question? So
Yes.
one, initially, let's say this is my first day on the job as a police officer. What are your thoughts for building resiliency skills, for trying to deal with what the risk factors are of being a police officer, and also what you perceive those risk factors to be?
I love to get a hold of brand new police officers that are still wet behind the ears. It gets me pretty excited, because it's an opportunity. And I'm going to validate that some of the things they are going to see are tragic, that there's a level of vicarious trauma based on how much you identify with the person that is having the serious incident. And there's a difference when children are involved. It's worse. When you see someone as not being an agent of their own demise, someone that is innocent and just in the wrong place at the wrong time, that's horrific. So I validate that if you're feeling upset, that's reasonable. And validating and educating is the first part of good treatment, is to help people to understand, and to help people to understand that even though someone else might be standing next to you at a car crash, and they're fine with it, you might not be, and that's okay. You have to honor what bothers you and what doesn't, because people, young police officers or new police officers, often feel strange that that one got them. Like they attended a death at a residence, and a grandfather on the kitchen floor who appeared to have lived a full life, and they were absolutely struck by that one, and they're almost upset with themselves. Why am I so upset by that? And you dig a little deeper, well, it kind of reminds you of your grandpa, and you really loved him. And the grandma, she just seems so sweet. So I mean, people need to understand that they're going to be upset sometimes. And resiliency training is about saying, if you are upset, first and foremost, accept that, honor it, punish yourself for feeling upset, regroup, do your job, finish what you need to do, and then take a moment. And when you take a moment, do that in a healthy way. That doesn't mean drink a lot of alcohol to take that moment. It doesn't mean to try to transition into the rest of your day without taking a moment. And this is where we talk about peer support, finding your cohort, finding people that are good with you. I've done a lot of debriefings over the years for RCMP and firefighters back in the day, and ambulance attendants. At various times, they've wanted psychologists to do that work. And when we talk about it, it's like there are individual differences, and it's nice for senior people to say, oh yeah, this one bothers me. It's bothering me too. This, you're early in your career, and this one is bothering all of us. Trust me, this is a big one. This is not okay. This is very difficult for all of us. And so validating it, and then processing, and then lifestyle management, make sure you take care of yourself, get your sleep. Be careful not to caffeine all day and then expect to fall asleep, because if you've drank caffeine all day, you can fall asleep, but you won't stay asleep. Because you'll fall asleep when you're exhausted, and you'll wake up when you're just merely tired.
Yeah,
And that won't be enough sleep, right?
No, that's fair. And yeah, I don't know of any cops. I didn't drink coffee at all till about 12 years service, I think. And then I don't know how I made it through after that. But yeah, and night shifts, that's a great thing. I don't know if maybe we'll talk to someone who's a sleep expert at some point, but night shifts are tough, right? Because you get your 12 hours from many, many places. You're trying to stay awake, so you're drinking coffee or energy drinks. Those are the new substance,
Yes.
right, that so many
Yes.
people are drinking. And then you get off at either 5 or 7 a.m. and you had your last coffee or energy drink to keep yourself awake at 3 a.m. Not really a great strategy to set yourself up for the following shift.
Oh, and we're segueing into lifestyle
Yeah,
management, aren't we?
yeah,
And I actually consult to the Kelowna Sleep Clinic. I have for years, and they eventually got an in-house counselor because I was doing a lot of work with them. Because you're talking to like a 32-year registered psychologist, yeah, I've done a little bit of everything. I'm quite broad in my training background, child and adult. Sleep, yes. I actually trained with a sleep expert, and sleep is complex, and it's patterned, and becomes ritualized, either in good or bad ways. Some people pride themselves in being able to fall asleep anywhere and sleep well and wake up rested. This can deteriorate over time when you're on shift work, and it can deteriorate over time when your anxiety levels are always rate on amber alert, and your adrenals are flowing, and yes, you're exhausted, but it's hard to sleep. So sleep hygiene psychologists that are trained in sleep know that if someone comes to you with a long-term sleep problem, it's not so simple as just making sure your blinds black out and you've got sound canceling devices in the room or on your ears. It's just not that simple. You lie down anticipating you're going to wake up in the middle of the night, or anticipating you're going to have night terrors, and you're predicting that outcome, and it's probably coming your way. So it's a lot of work to get people out of bad sleep patterns. It's not easy.
So, can I ask you a question about that? Because topically, I'm talking to my friend this morning, and he literally tells me uh, he had night terrors last night. He had a really bad day yesterday. Um, he has an emotional day, dealing with a bunch of shit, and he goes to sleep quite upset, and then wakes up with night terrors. How do you unpack that?
Right. So dreams and night terrors and such have been discussed since Freud and Jung were exchanging letters in the late 1800s and early 1900s. This has a long history. And I know people diss Freud, but I wonder if practitioners from today will even, their names will even be mentioned in 125 years, like Freud's is, right? So there is some lasting content from him. I really like to characterize night terrors as you've got unfinished business, you've got undigested business from the day, and you lay your head down exhausted, and you don't take any time to set the emotional tone for your sleep. And so you just sleep because you're exhausted. You haven't got a problem falling asleep. And then the Steven Spielberg of your dreamscape is going to do you a solid here and help you to cathartically release the emotional upset that you didn't deal with in the day. And he's just going to pick some scary stuff, some go-to stuff, because he's a bit lazy about it. This guy's feeling anxious. Let's pick some go-to anxious stuff. It might not even be relevant to what the day held, but it'll be relevant to the person. This is their anxious stuff. They might dream about snakes or fires, and maybe what happened to them today was more just an insult from an upline officer. And yet they're going to have these horrific night terrors, and they're going to wake up in a panic state and have a very hard time calming themselves down. And that panicked state, there's a state dependency to memory. So you're going to all of a sudden then all of the events that have ever occurred for you in that particular state will come to you, and then you'll have this litany of events in the middle of the night that go with the panic state that you woke from. This is how many of the police officers that I serve describe night terrors. My job is to suggest, let's set an emotional tone before you drift off. I know you're tired, but take 5 minutes, 2 minutes, and decide what you would like to dream about, and set a tone, and promise yourself that you're going to appropriately deal with the upset from today. You're going to talk to someone about it. You're going to speak to a colleague. You're going to seek professional help. You're going to take the time to address it to your own satisfaction. But right now you want a good sleep. So you picture yourself at that favorite fishing cabin. You engage in a fair bit of mind trickery to make yourself believe, when you're with your eyes closed, that these are the sheets on the cabana at the beach, or these are the sheets at the cabin, and the warm fire is over here. Some people will actually have sound devices that create an ocean sound, or a nice rainy sound to kind of contextualize themselves, and remember your fondest, best moments, and drift off with that. Give Spielberg something a little less frightening to consider at bedtime. Try to set the emotional landscape for something more positive. And you can get reasonably good at this, although some days won't let you. When you do wake up, all of the sleep literature suggests get out of bed, don't lie there twisting and turning, get out of bed, regroup, maybe have a light carbohydrate snack, a little bit of warm oats or something, because that'll take the blood supply away from your brain to digestion. Maybe put a heating pad on your neck to relax your neck wherever you carry your tension. Then lay back down and put yourself back in that that fishing cabin. And and remember all of the people that love you and all of the nice things that you've ever been told by all of the people that care about you. And that can be people that aren't with us anymore. And just try to really conjure up a different state of mind and decide what you would like to dream for the second half of your sleep.
Those are some great tips, and kind of goes. I think when I started, again, now not 33 years ago, but still, I'm almost 25.
Yeah.
It was sort of the training was, you take all those emotions that you've encountered, all these things that are horrible to see over time and they build up, and you put them in a box and you just shove that down, because it's not fair to express that to your family because they don't deserve to deal with that. And it's not fair to express it to your colleagues because they have their own stuff to deal with. And if you come home after work at 7 a.m. and have a bunch of drinks before going to bed, that's totally normal and normal behavior. And like, this literally was the training, right? That was what people were told. Now, was it official training? Parts of that were. The last one was where, right to the families. If your partner comes home at whatever time, doesn't matter, that's their Friday night. So if they're just going to start drinking in the morning, that's totally normal.
Right.
So,
Right. Yeah.
we're not
Yeah.
there now.
Yeah.
I don't think new police
No.
officers are being trained that. So we're coming along. And but what is and you gave some great tips there. But going back to Chris's question earlier about the new member. Like, what are some steps to take as soon as you become that cop? So they're not all 20 years old anymore, right? Some of them are 30 years old with two kids and a spouse that has a profession and whatever. So they're gone for their training, they come back, whatever that looks like. What do you recommend they say even to their families? Like, how do you start that conversation so it's I presume so you want it open, but are there some tips on engaging right away with family? How do we do that?
Right. Yeah, I mean, you've said a lot there. I mean, alcohol as a de-stressor has been a socially appropriate, approved choice and an encouraged one in the earlier years of the RCMP. It wouldn't be unheard of for there to be drinks at the detachment at the end of a shift. I mean, that's a long time ago. We don't talk about that anymore, but it's in the history.
Fight Club.
Or or head to the bar and have a drink now after the last the last day shift or something like that,
Yeah.
right?
Yeah.
So I get that. Alcohol is a depressant. Sorry. I mean, on cigarette packages now, there's pictures of lungs that are blackened and horrific looking and horrible pregnancy pictures and such to remind people, but the government's making some money off alcohol, and you don't see an excellent Merlot that says moderate depressant, or a beautiful bottle of whiskey that says severe depressant, and then it doesn't have to have on the label a picture of somebody slumped over with their looking like crap because they've drank a very large amount of depressant. It doesn't work that way. And alcohol is a tricky depressant because it's disinhibiting and it makes you feel good. But whatever it sells, it buys on the flip side. People feel somewhat depressed the next day, a little bit of morose, a little bit of worthlessness, a little bit of guilt. Like, you can actually, in a hangover, have some guilt. And you maybe didn't even say anything stupid, but you're checking, you're going back, and hopefully you didn't drink so much and increase the toxicity so much that you blacked out and you don't remember. That's even worse. And in those disinhibited states, what you said. So it's a state changer, but it comes with a great price. What do we say to spouses, and what do we do to transition? What we say to spouses is, I've had a good day or I've had a bad day. This has been a productive day, or this has been a day with a bunch of unfinished paperwork, which most people, when they sign up for policing, don't even realize is going to be a real thing. A whole lot of paperwork, right? And you guys are you're good at paperwork, but there's a whole lot of it. And there's a lot more paperwork for psychologists than I signed up for too. But it is what it is, right?
Yeah.
So, it depends on the spouse. It depends on the age of the kids, Mommy had a kind of a bad day at work, or daddy didn't have a great day, but I'm going to just have a shower. I'm going to stretch, and then I'm going to come back and we're going to have some fun. Maybe we can go outside. Why would I suggest a hot shower or a hot tub or a hot bath or a cold plunge? Because that will physiologically change your state. Maybe only temporarily, but it will change your state. Because when you are in a physiologically aroused state that is associated with anxiety, with stress, for some people with chronic PTSD or chronic generalized anxiety disorder, when you're in that state, you have a shorter threshold for irritability. You have less stress tolerance. One request from your beloved spouse could turn you over the edge. You're not in great shape. So a hot shower will move your blood supply from the fight or flight response into a preservation of body temperature response and make all of your skin surface red, which will be a, a priority so that you don't boil to death on the inside. When you go for a hot shower, your skin gets red, your blood supply shoots to the external body, and you feel more relaxed. And so that's actually a really good strategy. Exercise is an even better strategy. Some people will bike to and from work when the weather is inclined for that. And the shoulder seasons are best, and the other two seasons are kind of tough sometimes. We try to have gyms in detachments. I know that's, fairly standard. And having an exercise break is a form of flight. So when you get into fight or flight and your whole physiology is altered and you're feeling tense, exercise, your body isn't smart about this. It just thinks you've successfully ran away. Exercise is flight. Some people exercise in the form of martial arts where they're interacting with other people. That's fight, but it's a controlled fight. And those are ways to strategically reduce your fight or flight response, which is physiological. It has increased heart rate, it has increased respiratory rate, it has a change in blood supply to your large muscle groups. And let's I mean, there's so much to talk about, but post-traumatic stress disorder is a rising diagnosis amongst members of the RCMP and other police forces. And I consult too and do talks with a lot of different groups, and it's fairly common that people have unresolved trauma that becomes post-traumatic stress disorder. Their whole body is physiologically altered, which makes it harder to sleep. It makes it harder to relax during the day. It makes it quicker for you to be triggered. All sorts of things are going on. And lifestyle management, exercising will calm your body down. If you're really stressed, it might take an hour and 20 on an elliptical to get anywhere to feel more relaxed. If you're not too stressed, 20 minutes of aerobic activity might be enough. When your family's waiting for you, you have to explain, I love you, I miss you, I can't wait to get home to you, honey. But you want me sort of de-stressed from what was a very difficult day. So I'm stopping at the gym and then I'm all yours.
It's very generous of you to think that I could do an hour and 20 on an elliptical.
Hey, I've done it. I've done it at
That's a
various
lot of
times in
stress you're
my
working
life.
off there.
Yeah.
So something you broached on there, doctor, which I'd love to get your insights on. So the rise in diagnoses associated to police officers. Now, do you attribute that to police officers being more open, or do you believe that there are more factors that are leading to these conditions for us? Or what are your thoughts as to why there is an increase in that in this world?
Yeah. So often when is it A or B or C, the answer is yes. It is A, B, and C. So I have a number of 70-year-olds that have called the office and said, my grandchild or my child has said, I should reach out and because I'm a cranky curmudgeon, and I was a police officer for 35 years, and you don't hear that too often anymore either, right? I was a police officer for 35 years, and I think I've got some unfinished business. So I am diagnosing people that are, 20 years past their last operational day, and they have unfinished business because it wasn't cool. It wasn't okay for them to seek mental health care. That was not acceptable. With society, the RCMP has changed drastically. And it's quite interesting, actually, because I also provide service to military people. And within the RCMP, you have a lot of people working fully operational with diagnoses. And in the military, if you get a diagnosis, a mental health diagnosis, or a permanent lumbar lower back issue, you are out. In the RCMP, if you have these diagnoses, when can we see you back to work? Or maybe you never go off work. So the RCMP is open to recognizing that people do have diagnoses. Are they good at accommodating people with diagnoses? No. There's some mental health washing, just like there's greenwashing when certain organizations say that they're environmentally friendly. There's a bit of mental health washing in that regard, in that you don't really get accommodations for mental health, but you can get service, and you can go to an appointment during your operational day to debrief and stay healthy and stay in touch. I help lots of people to stay operational. Why is PTSD an increasing diagnosis? I mean, it didn't even really exist as a diagnosis. Our World War I veterans were shell-shocked. People coming back from Vietnam were kind of the first group where we saw something that was kind of a prolonged trauma-induced chronic something. PTSD has been a diagnosis for a long time now, but not a popular one. I'd say it became popular around 2000. And in 2013, the diagnostic criteria changed, and it included vicarious trauma. I was providing services to people from the 911 call centers, and in the earlier days, the call center was in the detachment. It was very personal. They would be, "See you later, Fred," and then they'd be like, "Fred, we need you to go to this call," and "Oh shoot, Fred's out of radio range. We haven't heard from him for a while. We better send backup. We don't know if Fred's okay, and maybe he got hurt." And then, or he comes back to the detachment, and you have coffee with him later. So call center people were actually vicariously traumatized by the things that happened to the members that they were serving and supporting. Now call centers are quite removed. A bit of a disadvantage, actually, because they don't even know when you say, "Oh, I'm at, Reed's Corner." Is there actually a street called Reed's? Like, they don't live in the community anymore. So it's complicated. But in 2013, we included vicarious trauma. So you just had to identify with it. You didn't have to be there to experience it. Police get a lot of vicarious trauma every day. When you see someone who is physically hurt, or physically their body parts don't fit together like they should anymore, and they're clearly not alive anymore, you will feel traumatized by what they went through if you identify with them. And PTSD has now broadened to include a broader group. This is beneficial in that it recognizes that you can have symptoms of PTSD. You can be negative. You can perceive the entire world as threatening. You can be at a restaurant with your family, and you've got your back to the wall, and you've identified the exits, and you're supposed to just be eating Italian food. You're not supposed to be assessing the environment and looking at, the people around you. PTSD can include a reactivity, a level of emotional upset that is disproportional to the situation. How do you still reach out to loved ones and let them know, "I love you, but I feel triggered right now. And there's a difference between, like, I know that was a disproportional response. I'm sorry. Let me regroup. I love you. I'll come back to you in a minute when I calm down, as opposed to just slamming the door and leaving because they don't realize what they've just done to you. Um, so we do acknowledge a broader group of people for the diagnosis, and members are allowed to get this diagnosis and keep working and get treatment while they're working, or take a little bit of time off and hopefully get back in a reasonable time, which we should talk about as well, because it's not really healthy to stay off too long. It makes it harder to come back. But then we get a group of people who would like the diagnosis and haven't really experienced much trauma, and they fancy that they have it, and it's a lot broader now, and it seems to be a much lower criteria to get there. And a 30-year-old member that's just starting to identify that they maybe have some trauma that's unresolved doesn't really appreciate a 2-year member who says, yeah, I've got PTSD, I've got a diagnosis. And it's like, well, what happened to you? Well, this, that, and the other. Oh, that doesn't sound like enough. like we get generational differences, we get tolerance differences. We also in 2013 changed the criteria to not just have the angry, acting out PTSD person, but to have what you were describing, Rob, the person that goes underground, the person that becomes avoidant and just buries it, and thinks they're doing a great job. They come home and they're not going to talk about work at all, and they're just going to be just fine. And then when their spouse is chatting with them, they're not fine. And when you say, well, it doesn't seem like you're fine. Well, I'm trying to be fine. Because, when you bury too much and you don't deal with it, the avoidance patterns cause their own extremely severe challenges. I've got people that have affairs while working, and they come in for treatment because their spouse catches them, because eventually these things get figured out. Don't imagine they don't. They get figured out, right? Like people say, I'm worried my spouse might be having an affair. I said, just wait. If they are, you'll figure it out. You don't need to go looking for it. Yeah. It'll land right in your lap. So people that have an affair, because they've practiced such perfect compartmentalization and avoidance, that they're living in this moment without thinking about this one, and their spouse says, well, what were you thinking about me when you were having sex with someone else? Well, I wasn't thinking about you. I love you. When I'm with you, I love you. I was just in a different place. So compartmentalizing can cause a few really icky problems. And then the person starts to reintegrate and realizes, wow, that what I did, I can now reintegrate in therapy and discover, to my horror, how awful that was for you. I don't even deserve you. Thank you for staying at my side in the cases where they do. And let's work this out together. So avoidance, like yes, there's more diagnosis. Yes, we'll look at the angry people. And you asked earlier, Chris, about like what should we be looking for in other people, or I think Rob, you mentioned, like, what should we be looking for in our colleagues? Well, they're going to express this differently. It's going to look different depending on who they are and how they were raised and what's normal in their family history and what's normal for the people around them that trained them. If somebody said to them, don't be weak, don't show emotional weakness, you'll never get promoted if you show emotional weakness. Well, maybe they changed their perspective. So some people just might get unusually quiet and look absolutely okay with a horrific file. They just look absolutely okay, and they're munching on their sandwich, looking at pictures of horrific scenes, and they don't seem to care anymore. And you look at them and say, man, I remember a time when that would have upset you. I'm a little bit worried about where your feelings are. Like, I'm just worried for you. Like, are you talking to anybody? Because do you want to talk to me? Are you okay? Versus somebody that's just reacting and saying that they're picking fight with motorists when they're off duty and somebody cuts them off, and they're civilian heroes now when they see anything wrong. Like, it differs, but it looks like the person just doesn't have the range and they're not themselves. So you kind of have to know them to know. Like you can't just come up to someone you've never met before and say, "Oh, I'm pretty sure this isn't normal," because maybe for them it's not bad.
So
Well,
it's about establishing baselines with your peers and your
Thank
friends.
you, Chris. You just did my work for me. That's it in a nutshell. Yeah.
yeah, that's so important. And I want to ask a little bit about organizational stress. And I don't mean necessarily from the organization at the top down, because we can have a lot of great organizations. The RCMP's come a very long way, as you said, on this stuff. Uh, but they're not the ones we're working with, right? Like that is not, we're not working with the commissioner. And I don't care if you're Vancouver, you're not working necessarily with the chief every day. You're working with your unit, you're working with your boss, you're working with your peers. So is there, like, in terms of organizational stress, is there some, I don't know if there's literature, like where does that come from, and how much does that factor in when you're talking about, you're going to see all this stuff. You're going to have to, if you're in uniform, you're going to be seeing awful things. Like that is just
Yes.
going to happen. You're going to experience those awful things.
Yeah. Yeah.
So if that's accepted, that is going to happen, how much of a difference can the organization, and I mean the organization being the unit, how much difference can that make in terms of outcomes?
Yeah. That's huge. And that is a conversation I have. If I see 8 people in a day, I probably have that conversation 7 or 8 times with RCMP members. So the RCMP is a constantly shifting organism. Your corporal won't be your corporal in 2 years from now. A sergeant that you like or don't like, if you love the sergeant or the staff sergeant, you're going to, if you love them, it's going to feel too brief before they're gone. If you don't like them, it's going to feel endless before they're gone. But they're going to be gone. They're going to move on. It's going to shift. There's always transitions. I tell people, you're just looking for your immediate circle, your immediate cohort, that you feel a sense of trust, that people have got your back in your immediate team, that you're there for each other, and people will stay at work and they will be functional and productive when they have an immediate circle of people who they work with, who they trust, who they appreciate, who they respect. They debrief each other in small ways. They are peers, and their upline command structure is offering them a bit of autonomy and a bit of trust, and they've got their back. There was a recent example of that where an officer in charge stepped out into the media and said, look, these are good members, and there's more to this story, and but we can't get into it because we're not allowed to. But these are good members doing a good job. That is huge. If you go a little bit further up line to the person in charge of a detachment, it's also really important, though, that that people feel the love and the immediacy, because people will say to me, "I want to stay at work. I don't want to let my peers down. I don't want to make my watch short, because I know what that feels like for the people that are left. I don't want to be that person. I want to show up." And when the women and men that are providing for frontline services are showing up for each other, and if one of them's exhausted, the others will look and say, "Look, you go sit in your police car, get some paperwork done. We've got the next couple of calls. You look exhausted." And that was a real bad one that you just took. That's camaraderie. That's a beautiful thing. And those are the people that can stay. Unfortunately, we get this cascading effect if there's some toxicity upline and somebody isn't treating people with real respect and not operating with a moral high ground for leadership. I think it's really important to not just talk about what goes wrong, but talk about what leadership can look like. Talk about making sure that leadership is respectful and has some common humanity in how the decisions are made. And when hard decisions are made, that there's a moment to say, "Look, we have to do this for the following reasons. Sorry. We get that this makes it hard. We appreciate you." When leadership calls people together, and there's massive shortages of members, and the leadership calls them together to chastise them, then what happens right after that meeting is a whole bunch of other members go off. Like they can have a positive or an adverse effect really quite quickly. If they micromanage, they can have an adverse effect, because micromanaging says, yeah, I don't even trust you to know whether to wipe front to back or not.
Mm-hmm.
So I'm just going to be all over that.
Yeah.
That's suggesting that I have no faith in you. Telling people that you have faith in them and that you've got their back is wonderful. There's limits to that, of course, but everyone knows that. So in a small group setting, I see people sticking together and showing up. And when someone's off, I see them reaching out for coffee and coming together and saying, "Hey guys, I just reached critical mass. I asked for more antacid because I was getting a lot of gastric reflux, and my doctor said you can't take more. That's your anxiety. You can't even digest anymore. You need to take a break. But I'm coming back to you guys as soon as I can calm this down. How's it going?" Right? Those kinds of amazing relationships where people will come back and people will feel supported in coming back. It's a bit of a segue to the physical ailments associated with mental health, which I'd like to address too. But
Yeah.
if you have more.
Please do. Yeah.
I just want to ask one question before we switch, because I do see moral injury as like one of the more prevalent injuries to police officers in general, whether that be the watch, the squad, the platoon. But like, I think members, we mentally prepare for things to suck at work, right? Like we go there to make a difference, we go to help, but I anticipate seeing dead people. I anticipate violence. I anticipate trauma. But that sense of when it's happening in your unit or it's happening with your supervisor and you think, but you're supposed to be on my team. Like, that I've seen, I think, more of, and it seems to hurt members more, or at least my perception is.
You're right. And I think there's a lot of variables that have impacted this, because there's also like a media presentation where we're not allowed to step up and say that person that just was involved in that shooting, that police officer involved in that shooting, that's a good guy, he's a good cop, he's an awesome guy, and we're going to fully investigate this. From a media perspective, that doesn't feel right or good. But on a softer level, you come in from a horrible crime scene, and your command chain leader looks at you and says, "Where's all your paperwork for the last 6 blah blah blah," without any sensitivity to where you just came from. And they hit you with something else, and they're insensitive, and they don't seem to have their finger on the pulse of what's going on. That's happening a lot. And I see it happening more and more. The "I've got your back" used to be the standard when I started, and it isn't anymore. "I've got your back" isn't the first thing out of the lips up line. And I wish it could be, to the degree that they can do so without breaching any official rules of the organization. I wish they could say, "I've got your back, and look, I expect you did this well. If you didn't, please tell me so that we can manage this."
Yeah, when they say I've got your back, we shouldn't infer that means a sight picture.
Right. Yeah. Yeah.
Yeah.
Yeah, exactly. And there's more and more of that. And there's areas within the organization that pop up. Like I provide services to mostly the Okanagan region, but I've done debriefings as far as a helicopter can fly in an hour and a half. So I've done debriefings all over, and I can provide services to anyone in BC, and we do remote services for people as well, where they don't have psychologists in their own home region. We have a good remote program, but the idea that there are toxic workplaces, and the organization doesn't really know what to do with that. It doesn't really sort very well. And when people ask for a transfer because they don't like a toxic leadership, they don't really get it. They just have to look for promotions, or they have to accept less popular postings to get out. And when you see people leaving and leaving their family behind to finish high school, because they just can't work in an environment anymore because it feels toxic. That seems wrong to me. And I used to be able to do more about that. It was smaller when I started. There was, there like health services was a very small office when I started. Dr. Roland Bowman was a part-time psychologist, and he would rely upon me. Heather, go and talk to them, see what's going on, what's happening with Kelowna detachment. Go and chat with the OIC. And I'd sit down and we'd talk, and I'd try to demystify what was going on and make a difference and say, yeah, you're kind of being received in a way that I think you don't intend to. You realize that's causing an impact. That's not my role anymore. I'm supposed to stay in my lane and only talk to the person about their mental health as if a toxic workplace doesn't have an impact on that. It's very tricky. There's a section in my progress note that offers me, are there any external factors? And if I were to say, yeah, toxic management, and there's a grand revolt and no one really wants to be there anymore, they would say, yeah, that's not really your lane. But isn't that relevant if I'm all of a sudden seeing a bunch of people from one detachment? Because it switches. We have great detachment leaders, and we have detachment leaders who seem to not be appreciated by their members, and they're getting management training, but I think it's more important that they please the upline than the downline.
Yeah,
And
you nailed it. It's
yeah,
management. It's not leadership.
No, and
right.
we've talked about that, right? That those two words are often used, sort of interchangeably, but they're not really interchangeably in my mind, at least, and I think Chris is as well. Like they are not the same thing, and you can be a good leader and also not a great manager, because managers to me more dealing with the stuff than the people, and we need to make sure we have as many leaders in place as possible to make sure that
Yes.
the bad stuff, like, so we've talked a little bit about some strategies early on. We've talked a little bit about the causes, but yeah, I do want to get into the sort of the physical. So you're in it now, so you're a member.
Yes.
You've This
Yes.
has happened. You've now
Yeah.
got PTSD or major depressive disorder or whatever it is.
Yeah.
But
Yeah.
without going into all of them, because there's a lot, let's go with PTSD because I think it's the number one,
Yes.
right? So what are the
Yeah.
physical things, and is there a way to deal with some of those individually, or do you have to go to the root cause? Like, I guess, so whatever the physical ailment is, um, can that be addressed on its own, or is it sort of necessary to deal with how that came about?
Yeah. We're talking about chronic cases now. If someone has been like, if you have an acute stress disorder because something traumatic happened, it might not evolve into post-traumatic stress disorder, but in policing, it often will because you're going to get ongoing new exposures, and now you're going to get thematic exposures. These are all the smelly horrible things I've witnessed. These are all the child related things. These are all the innocent people stuff. You start getting like a repertoire of categories of traumas, and so you will eventually likely have a diagnosis of post-traumatic stress disorder if you can't continue to shake them. And treatment for someone that's still operational versus someone retired is very different with different prognostic outcomes, which is why some people medically discharge because the treatment isn't progressive enough for them. So if it's chronic, if I've got a 40-year-old, I'll say to her, we've got to watch this because if this carries on for another decade, you can have consequential physical ailments. If I've got a 60-year-old that says that their symptoms go back to 25 years ago, then I'm like, okay, let's do an inventory of what your illnesses are. Veterans Affairs Canada is the official body that assesses RCMP and military individuals to determine whether they have a work-related injury. And once established, for example, that they have a PTSD work-related injury, they will accept consequential applications for physical ailments. And I participate in that by writing the consulting letters, the psychologist explaining the relationship between PTSD and the consequential illness, and the reality that it is consequential to chronic PTSD. Let's just start at the top of the head and work our way down, shall we?
Sure.
So, I mean, there are physical injuries that come from the workplace. There can be hearing injuries. There can be all sorts of injuries that are the result of carrying a weighted belt, working in a small confined environment like a police car with your prime computer off to the side, and moving around in close quarters, actually having to struggle with individuals that become dead weight and move with them. And those physical injuries can remind you of traumatic injuries and interact with your PTSD to make you worse. But there are certain physical injuries that come from PTSD. And it's because of what living in a constant state of fight or flight does to the human body. In a constant state of fight or flight, where you're never really back to that calm, chill person. You go on a vacation and you maybe get it back in bits, but you don't get it back completely. And then that physiological upset just comes right back to you again. Eventually, it doesn't go away on vacations. Eventually, it stays, and you really worry about that. That constant state results in a change in respiratory rate, heart rate. It causes cardiovascular stress. People are more prone to cardiovascular disease, hypertension. People can have physical diagnoses that then require treatment as well. And you want to treat all of the conditions in parallel, in series. Because of my health psychology background and my master's in health, as well as a PhD in clinical, I really look at the physical human body, the whole body. So cardiovascular issues are a big deal. Respiratory issues can sometimes come because you can end up with chronic poor immune system results from being in fight or flight all the time. Your immune system works during restorative sleep. It works with a healthy gut. You need to have a good lifestyle. You need to sleep well. Your immune system starts to fail you. We have approved conditions for things that you might not have expected would be consequential to PTSD, like people with Lyme disease, because while they were working, they got a tick bite and their immune system couldn't fight, and they didn't get treatment in time, but it's work related. People with young people that shouldn't be getting shingles, and we have approved conditions through VAC for shingles, because the person was run down. Like, a 40-something-year-old shouldn't be getting shingles that, and these have to be permanent conditions with Veterans Affairs Canada, where there's lasting, in that case, it would be a lasting injury because of the site of the shingles. We have gastric reflux, GERD. So GERD is basically that your acid in your stomach rides up through your esophagus and burns your esophagus, and you end up with problems in digestion, starting with gastric reflux disorder. And that is an approved consequential to PTSD, because the blood supply is going to the large muscle groups, preparing you for fight or flight, and it's not going to digestion. It's we have individuals with bruxism, which is a tightening of the muscles of the jaw to the point where people grind and ruin and destroy their teeth. That is consequential to PTSD. So cardiovascular issues. We have individuals with metabolic syndrome, which means that your insulin response, you have insulin resistance at this point. You can't lose weight. You pack on extra pounds. You're having a hard time. You can get to type 2 diabetes with this. These are all consequential to PTSD. Young men with low testosterone, 38-year-olds with low testosterone, consequential to PTSD. And understand that the medical service plan is overwhelmed. So I have to take a moment to talk about what your family doctor might say about whether your testosterone is low or not. The medical service plan keeps moving the range of what's normal for testosterone. And normal is getting pretty, I mean, a fellow could have no libido, no sexual desire, might even have some erectile dysfunction issues and be in his early 40s. But according to the MSP, it's normal. But is it really normal? People have access through the RCMP plan. You have access to naturopaths, which would take a deeper dive. You have access to clinics that do deeper dives into a relative comparison of all of the hormones involved. Women can have a loss of libido, and they can have all sorts of sexual dysfunction disorder as well. And what we find is that you have to look at the physiology as being compromised because your system is putting you in fight or flight, amber alert all the time now. So you're not sleeping well, you're on edge, and that's not a system that engages in normal repair. Certain cancers are now accepted by Veterans Affairs Canada as consequential to PTSD.
Wow.
And those cancers, it depends which one, because it varies, and some of it is based on finding the literature and finding the supporting documentation. I've personally been involved as a senior psychologist in finding and determining the first person to get a diagnosis that is determined to be consequential to PTSD, just based on my background in physical knowledge and health psychology as well as clinical. So it's one case at a time. We're a Commonwealth country. It's case law. It is established and determined over time. But you can look on the Government of Canada Veterans Affairs website and see the approved conditions and consequential conditions under physical ailments. You can see all of the different conditions that might be there. And what you need to do is talk to someone who's knowledgeable. Your family doctor may not realize that connection. And unfortunately, if it's a physical ailment, you are doing an application, a medical questionnaire completed by typically a family doctor, whether sleep apnea is consequential to PTSD, restless leg syndrome is consequential to PTSD. Once you establish these claims, then for people that medically discharge or retire, they'll get continuous service with Veterans Affairs Canada. And they don't dispense a great deal of funding for these claims, but it would give you a CPAP machine. You'd get covered for the medications you would be taking for type 2 diabetes. And yes, we can treat them in combination. And this is a bit of a Debbie Downer conversation, so let me give it a positive twist. When you get educated about how all of these things relate together and you start taking care of your mental health and your physical health, you can kill a bunch of birds with one stone when you start to address your mental health and lifestyle management that helps your mental health and your physical health. You can turn these things around. You can turn around some of the symptoms, and you can get way healthier than you have been in the last decade. But can you do that while you're fully operational and the demands are great and you're overwhelmed? It's not easy, but that's my first goal, is to help people to stay operational, because people don't feel good when they're off. It's not a vacation.
No, that's good.
Even more guilt, I think. Like, I would say we have this mentality that's kind of driven into us. For us at Depot, at the other people at their institute, like the Justice Institute or the Atlantic Police College, wherever you go, but you're a part of a unit, you're a part of a team, you move as one, like anything you don't pick up for weight, the person behind you, in front of you picks up. Mm-hmm. So metaphorically and physiologically, that becomes like, I'm gone, my friends are carrying my weight. And there's this sense like, I wasn't strong enough, like their arms are still up, why aren't mine? And so when we're away in the workplace, I think people spin even more. Like, I think people are staying even though they need to go get that help.
Yes.
But when they walk back and they do raise that hand, then that chance of spiraling is so much greater, because now you're alone. you're confronting the reality of the fact that you did need this help, and the people are still doing their shifts. And so we tend to isolate ourselves, I would say, in our social lives as well. Police stick
Yes.
to police, we stick to other first responders. We all know it's negative, and somehow most of us still haven't figured out how not to do that.
Yeah. 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 Yeah.
But like that, I really think so. It's my first day off. My doctor said, "Yeah, no more Gaviscon for you, Chris." What do I do? Like, what do I do at home that day besides lament?
Right. Intermittent fast, give your digestive system a break. um, to correct your insulin, to reduce your insulin down to a reasonable response. Eat up all of the glycogen chains in your fatty liver. We probably all have a fatty liver if we live in Canada, where there's a lot more nutritional resources than we need. Eat whole foods, eat healthier foods. Try to take snacks with you. Try to prepare just a great big pot of healthy food that you can put in the fridge and bring bowls out and take with you. Order salads online. I order salads online. Exercise. Get out in the woods. Touch a tree. And walk barefoot when you can. Look at your environment in awe. And try not to gather to drink alcohol. Try to gather to do and to enjoy and to make outings of it. Try to make those multi-generational outings. Try to include people that would be your parents or your grandparents' age, if you don't have those folks, people in those age groups, and younger people. Try to reorient to healthy outings. And if you're off sick, most people don't even want to be caught at a movie theater or laughing in public at a coffee shop, because they'll see me and they'll say, "Why aren't I at work?" And I have to train people to say, if you see someone and you're out golfing and you're off sick, you tell them, doctor's orders to get out and physically regroup so that I can get back to work.
Well, we eat our own in many cases on that stuff,
Yeah.
and
Yeah. Yeah.
um, and from some perspectives, I get it. Everybody's short staffed, and there's more work. I get it. I do wish, I take a lot of, I think we're nearly going to wrap it up here soon, but
I just have one more piece I really want to get to the doctor about.
Do it. Yeah, go.
It's a completely different topic, but it's all about psychology. So if you want to touch on this, I just want to, there's one more area I'd like to explore. Very cognizant of your time, Heather. So I guess for me, a different aspect is we've been talking about a lot of singular psychology, but as a police officer, often I feel like the world's against me. And so that is like my issue. But I guess that issue becomes mine as a result of the fact that I don't think the public understands my job. I use force. Sometimes I have to use force in a very public area. Every a-hole in the world has a smartphone. They take
Yeah.
multiple
Yeah.
videos.
This is how they're helping now.
That's right. They clip it to show just one part of this,
Yeah.
not the entirety of it.
Yes.
But like that public perception, that public psychology of how it is that police officers are supposed to do their job. Why don't people understand us?
Okay, well, our society is fracturing and it's fragmenting. So let's make sure that this isn't a podcast for just police. Let's make this as big as we can. And this is why I accept every opportunity to speak publicly and reach more people. We are fragmenting to where there are false dichotomies. It's black and white thinking. Are you enforcing the law, or are you a citizen who is checking to make sure you're not using too much force? And those two groups no longer have overlap. And as a society, we're more fragmented. So educating, informing, trying to help people to understand and to be as broad as possible in helping people to understand, I think is super important. And I share your distress. And we can't speak to the media, as police officers can't speak to the media about a particular case, but we could use these opportunities to educate and inform. I've talked to the media representatives over the years, and sometimes we can do a good job of coming out, speaking compassionately. Sometimes the people speaking to the media are inspectors, and they can come out, speak compassionately, and say, look, there's an amount of force that needs to be used to protect all of you. And when you guys are all running away, we're running towards the bullets. We're trying to protect, and it's a hard job. And I can't speak about this particular file, but I can tell you that it's a tough job. We could use some compassion and understanding for our members. And if you see them, say thanks. If they pull you over for a traffic infraction, thank them for the work they do every day.
I don't know I go that far, but like just the general gist of, why is it that I as a police officer have developed an us versus them? Because I don't, like I shouldn't. I love
No.
my community. I love the people. But
Yes.
then I watch the news and I think, why do these people feel like this against us? Like why? When all we do is risk our lives for them. What part of my brain is wrong? And then what is it that is happening to the public? Like, is it a disinformation? Is it all a me issue? Because it certainly could be.
I think there's a narrowness to what is newsworthy right now in the on the television. I think there's a narrowness to the newsworthiness. I think it's broader when you get to streaming services. I think it helps people to have insight into their neighbor or their other professionals' perspective on what they're doing. I think some people, generationally, older people, respect what police do more because you guys got a lot more positive press in the earlier days. And you're not getting as much positive press now. But young people also do rely a lot on streaming content, and they're not so keen to watch, cable. How many young people have a cable subscription, right? So let's just keep doing what we're doing here. You're this fragmentation of society is something that is on the radar of when we meet as a group of psychologists. I've got a very large team, and when we meet and talk about this, one of the younger psychologists recently mentioned to me, like, this fragmentation, it's like people have different realities. People see the same scene or event and they have different realities immediately. And then we've got these algorithms on online services, on all sorts of social media engagement processes, algorithms where if I were to search the subject of, police officer using too much force, then I'm going to get more and more and more of that stuff. I encourage people to state an opposite declaration in your search. I will make a search term that makes me look like I'm far right of right. I'll make another search term that makes me look like I'm far left of left, and you'll get very different content. And you should welcome that, because we're not just going to get, unfortunately, there's no more mainstream media or traditional media that walks an objective, neutral path. We don't have that anymore. We don't have that newscaster where we can say, oh, this is good because this is going to be a neutral, objective representation. We no longer have, after an election is completed, we no longer have everyone just automatically saying, well, let's just respect the office now. Like, you still know who voted liberal and who voted conservative federally long after the election is over. Instead of people just saying, well, this is the person in the office and I respect the office, and my fellow Canadians voted for this person, and whether I did or not, let's embrace and do the best we can, right? Like this extremism, and don't forget that it's bleeding up from our southern neighbor, and they're even more extreme, and they have people who love the police and they have people who want to get rid of the police completely. They have very extreme differences. So as Canadians, could we do better? Could we help people who aren't police officers to understand a little bit more about what policing means? And of course, when we have the time and the luxury, when we have liaisons to the schools who go into schools and kids get to see police officers in uniform coming in to chat with them and being a liaison to their school, that's a positive thing. When we have news events where we have an opportunity to speak and we can educate a little bit, that's a beautiful thing. What you're doing, I hope it has a broader audience than police officers, because if someone from the regular public were to have listened to that list of illnesses you can have consequential to constant trauma exposure, and the fact that PTSD with all of those illnesses that is severe and resistant to treatment leads to a foreshortened lifespan. Like, that's heavy stuff.
Yep.
I'm here working every day, one-on-one with clients to help them to get that lifespan up and healthier and get that quality of life returned. But I'm also very open to doing conferences, and I do a lot of public speaking. Kind of shut down over COVID, and the public speaking format didn't really come back fully. It's got more of an online, and people just want to stream it when it's convenient and watch it for a while and see if it grabs them or not, but not like dedicate themselves to going to a great big auditorium anymore. But the more we can talk to a broader audience and bring us all together, so that people understand you and you don't feel ostracized. And I mean, I try to coach members what to say to members of the public, like, hey, I could use a little help here. Could you please be of some assistance, rather than just documenting this?
Yeah, fair enough.
Right. It's tough though. It's hard when I'm called to speak in various venues. It's even hard to broaden the conversation. I'm really just called to speak in a very narrow way. And if I try to broaden it and say, but let's look at the bigger picture, it's not always a welcome thing, which is why a longer format podcast, I think, is the way to go. It's why I didn't hesitate when you reached out to me.
Well, we really appreciate it. And and I will say 100% our intention is to have as broad an audience as we can. Obviously, we're going to be talking about issues that are police related and police adjacent, and that's primarily what we're doing. But the idea is, let's get this message out and demystify some of the stuff that's going on with cops, because it's not talked about enough. There's lots of reasons, we've discussed them a bit in the past, but very much appreciate you, all you're doing for everybody you treat and deal with. 14 years of education is that's a lot.
Yeah.
That's heavy.
Yeah.
So thank you for doing that, and look forward to talking to you in the future. And there's so many more topics we could be talking for hours.
I think we could, and I welcome that. There's lots of topics. There's lots of kind of reform topics too, around how to profile for promotions, how to choose people who are going to meet all of the needs and change the culture quicker. There's so many amazing things that we can chat about, and I would love to do that.
Awesome.
We would love to have you again. Heather, again, I'll just echo Rob quickly, because you deserve it. Thank you so much for what you do for our members and for the public in general. Your time today was invaluable. Thank you for sharing this message with our listeners.
You're very welcome. You too. Carry on the good work.
Thanks very much.
Okay.
Thank you.